Hello and good afternoon, everyone. Thank you for joining us today. The date is April 27, 2022. We thank you for joining our webinar series. We're kicking off with webinar number 1 about the unique role of MLPs, or medical legal partnerships, in helping health centers address disability and chronic disease discrimination. We are very happy to be joined today as co-NTAP partners in this webinar series. So I'm Bethany Hamilton from the National Center for Medical Legal Partnership. And the National Center is partnering with Health Outreach Partners, and Cindy Selmi from HOP is on today's webinar. Webinar number 1 in this series is going to be covering Disability Discrimination 101, understanding the legal protections, common barriers, and role of health centers in ending discrimination. Just going to cover a couple of housekeeping points to help everyone feel welcome and able to engage in today's webinar. So you will all notice that we are using the Zoom platform. You may also notice that we are joined by 2 ASL interpreters on today's webinar. If you need any additional support for engaging or hearing or utilizing the Zoom platform, please feel free to use the chat or other functions to communicate with us and let us know. Speaking of the chat, you are welcome to use the chat function to provide commentary as well as questions that we will be, as panelists and hosts today, using and paying most attention to the Q&A function in Zoom. Again, if you do need any support with engagement today, please don't hesitate to use the chat to communicate with us. Use the raise hand features in Zoom, even send us an email if you must. Let's go to the next slide. All right. When you joined Zoom today, you noticed we are running a poll. So as folks continue to log in, let's just take a moment to make sure we know who's joining us today. Let's do a few icebreakers. So that I know the first polling question is not showing up on my screen at the moment. Hopefully it's showing up for everyone else. But the first question is, what's your favorite pizza topping? We had a couple of choices, and I can see some responses coming in. Is it just cheese, please? Are you the whole shebang? Are you meat lovers type of pizza person? Or maybe you just don't eat pizza? So far, interestingly, most people are just cheese, please. Very interesting to see that. So if you're just joining, please go ahead and take our icebreaker poll. Folks are still joining today's webinar, so we want to make everyone feel comfortable and welcome. The second polling question is, we're on a webinar today. Are you looking forward to an in-person conference in the future? The majority of people have answered so far to the first option here, which is yes, because I've attended over 1 million webinars. I'm over it now, over the pandemic. Yes, I'm looking forward to seeing my colleagues again, only 8%. Maybe about 37% of folks say maybe they're ready, and no, for another 10% of folks joining us today, they're only going to be traveling for vacations. I can't blame you all. Great. So who's joining us in the audience? This is a HRSA-supported webinar series with our target audiences of health center staff as well as civil legal services providers. But we know that working in the community involves myriad partners. And so let's see who's managed to join us today. We have about 7% of attendees from the health centers. We have about 62% of our attendees from civil legal services. Some of those we know are with health center-based medical legal partnerships. About 5% of our attendees are disability advocates, 7% are from hospitals, 5% are from universities, academic institutions. And then there's a huge other category, about 14% of you. We're really curious to know, especially for our panelists today, who's in the other category. So let's go ahead and start using the chat and let us know if you filled out that other category, where are you from? I'm going to go ahead and end the poll, share those results so everyone can see it, and get started with the main presentation. I'll be very brief. Again, I'm Bethany Hamilton from the National Center for Medical Legal Partnerships, and I just want to provide a little bit of background as well as information about how medical legal partnerships have always operated in this space. So what is a medical legal partnership? This is the model or approach where we integrate legal professionals into healthcare settings to address those social barriers that have legal underpinnings and prevent population health from being improved, individuals from accessing care and improving their own health. And we also know that MLPs engage in a sorts of strategies and approaches that can address the policy barriers that prevent health equity around our country, and if you're looking at global health issues globally as well. In the history of the medical legal partnership movement, especially looking at our HIV/AIDS epidemic, we saw health centers with their legal partners really work to address chronic disease discrimination and help individual patients and communities access care and get rid of those barriers to everything from housing to medication, prescription assistance, guardianships. Those are the sorts of things that we know MLPs working together, legal partners and healthcare partners have always come together to address. And what we're hoping that we can get across in this webinar series is really building up to, from foundational information to that MLP webinar and webinar number 4, providing everyone with the information, the content, the foundational and substantive information you need to really understand how patients are affected by chronic disease and disability discrimination, what health center staff can do to screen for and provide strong referrals to your legal partners in the community, and then what you can do together in this MLP approach to serve as an intervention for individuals, clinical teams, and entire communities through policy change strategies. You can find more information about how to build an MLP to address myriad issues that are faced by patient populations served by health centers in NCMLPs, bringing lawyers onto the health center care team to promote patients and community health. We call that the Health Center MLP Toolkit. And when we put out the recording and the slide deck for today's webinar, that will be hyperlinked, and you'll receive that link to be able to get and download that toolkit. With that, I am going to pass the mic on to our primary presenters. And so Katie Hathaway has joined us. She's an NCMLP consultant, and she'll be taking over from here. Thank you.
Thank you, Bethany. I'm Katie Hathaway, as Bethany mentioned. I'm a white woman with long, straight brown hair and brown eyes wearing a purple shirt. My pronouns are she, her. I'm excited to be here with you today. I'm here in my capacity as a consultant for the National Center, leading this webinar series, and I brought on some of my good friends and trusted colleagues to help me present this information today. I have nearly 20 years of experience as a disability rights attorney, and I spent 17 of those years building and then leading the American Diabetes Association's legal advocacy program, whose goal was to end discrimination against people living with diabetes. So let me introduce you to today's speakers, and if it sounds like I'm reading their bios, it's because they are very accomplished and I don't want to get any details wrong. So first up on your screen is Brian East. Brian is a senior attorney at Disability Rights Texas, a nonprofit corporation advocating for the rights of people with disabilities. Brian worked at Legal Aid and in private practice before joining Disability Rights Texas. He's handled a number of disability discrimination and disability rights cases in both state and federal court, and has written and lectured extensively on these issues. Brian is a board member of both the National Employment Lawyers Association, otherwise known as NELA, and the Texas Employment Lawyers Association, known as TILA. He served as chair of NELA's Disability Rights Group and has also served on the Legal Advocacy Subcommittee of the American Diabetes Association, as well as on the legal committees of the National Disability Rights Network and of AIDS Services in Austin, Texas. Brian is a widely sought after and respected expert in disability and employment law and has received many awards of excellence for his service on behalf of people with disabilities. So thank you, Brian, for joining us. Aaron Fischer is a lawyer in the San Francisco Bay Area, where he provides legal counsel and representation on a diverse range of topics, including disability rights, employment, prisoners' rights, and complex class actions. Aaron previously served as litigation counsel at Disability Rights California and was an attorney at Rosenbein, Galvin, and Grunfeld, a San Francisco-based law firm. Aaron was a Skadden Fellow at the Children's Law Center in Washington, D.C., where he provided legal services through a medical legal partnership with what is now known as Children's National Hospital. Aaron lives with type 1 diabetes and dedicates a significant time advocating for the rights of people with diabetes who face discrimination at school, in daycare and camps, at work, and elsewhere in the community. And thank you, Erin. Glad to see you again. Cindy Selmi, as Bethany mentioned, joined Health Outreach Partners as Executive Director in November 2019, bringing over 30 years of health center and nonprofit leadership experience. Prior to joining the Health Outreach Partners team, Cindy worked for Planned Parenthood Northern California, most recently as Senior Regional Director for Contra Costa and San Francisco Health Centers. Cindy is a recent graduate of the Clinic Leadership Institute, a joint venture of the Health Force Center at the University of California at San Francisco and the Blue Shield Foundation of California. She started her health center career volunteering for the Haight-Ashbury Free Clinic, which fueled her dedication to health equity and assuring access to healthcare for all. So thank you also, Cindy, for joining us. Couple of initial things before we jump into the real meat of today's webinar. On the screen, I have the learning objectives for this entire series. And just to go over these really quickly, by the end of this series, we hope that you'll be able to screen for disability and chronic disease discrimination faced by your patients or clients and engage in certain resolution activities. You'll have a basic understanding of the legal protections and the common barriers faced by those patients and clients who live with disabilities, and you'll gain tools to help grow a disability or chronic disease medical legal partnership. So I want to talk a couple of terminology, a couple of words to make sure that we're on the same page and that we are coming from the same understanding before we jump in. And they are two of the words that are in the title of this series, disability and discrimination. It's important to understand the different uses of the term disability and how the word disability or disabled can be really critical to protecting your patient or client's rights. You may even have some discomfort in referring to your patients as disabled, and it may be a word that they themselves do not embrace or don't like, but nearly all people living with chronic disease today qualify as having a disability. So I encourage you to embrace this term at the very least as a tool in your legal toolbox to protect your patients' or clients' rights. The law requires that before a person even have an opportunity to make their case that what happened to them constituted illegal discrimination, they first have to convince a court that they are covered by the law, that they have a disability. So there are two main definitions of disability that you would probably encounter. One applies in the anti-discrimination context, which is the focus of our conversation today and for the rest of this series. And the other applies to applications for disability benefits from the Social Security Administration and related Medicaid eligibility. So under anti-discrimination laws, a disability is a physical or mental impairment that substantially limits one or more major life activity, or a record of such an impairment, or being regarded as having such an impairment. The definition under the Social Security disability insurance is the inability to do any substantial gainful activity because of a physical or mental impairment that can be expected to result in death for at least 12 months. Whereas the Social Security Administration focuses on a person's inability to work, the definition used in anti-discrimination law focuses on the myriad ways that a person's condition can impact them, including working, but not limited to that. There is a non-exhaustive list of major life activities that includes the operation of major bodily functions, and it's a pretty broad list at this point. So an example of what we call the first prong of disability, what is sometimes called an actual disability, is diabetes, cancer, HIV or AIDS, epilepsy, etc. An example of the second prong, having a record of a disability, could be, for example, having a past major depressive episode. The third prong, being regarded as disabled, requires a belief that the person has a physical or mental impairment that is not transitory, which means lasting 6 months or less, or minor. And finally, when we're assessing whether something is a disability under anti-discrimination laws, we look at the condition in its untreated state without any mitigation. This can sometimes seem counterintuitive, but it's very important that we focus on the bodily system or the function that the condition impacts and not how well they live with that condition. So the next term is discrimination. What does that mean? It can be used frequently to describe situations that feel off, but really whether something is or is not discrimination is a legal determination. And we'll discuss in a minute or two what the law requires in some common discrimination scenarios. But discrimination generally is unfair or unfavorable treatment of a person with a disability because that person has a disability, has a record of a disability, or is perceived to have a disability. And as you can see on the screen here, some of the examples of what disability discrimination include are a failure to provide a reasonable accommodation, an impermissible medical inquiry or examination, harassment, failure to make a reasonable modification to a policy, or perhaps denying or failing to provide effective communication. So with those two terms defined, I will turn it over to Brian East to discuss the basic legal protections.
Thanks, Katie. This is Brian. I am a white male I have gray hair. I've shaved since the photograph in my introductory slide, and I'm wearing a gray and white checked shirt. I don't think we expect that everybody will have a full understanding of all the laws and all the things they apply, but I'm going to go through some of the main federal laws. And I think the point that we want to make is there are a lot of laws that protect individuals with disabilities, and they are in the employment context, but in other contexts as well. And so most people are going to be protected by one or more of these laws. The first law that is mentioned on the slide is the Americans with Disabilities Act, or the ADA. And that prohibits discrimination in a variety of contexts. Title I talks about employment discrimination. Title II talks about discrimination by non-federal governmental entities, state and local government. And Title III talks about discrimination by public accommodations, which is the term in civil rights law for private businesses. And there are also provisions in the ADA that create opportunity and equality in communication and in transportation. The second law is the Rehabilitation Act of 1973. And this law did a lot of things, but the part that we're going to be talking about or referencing, or that is relevant to today's discussion, is our Section 504 and Section 501 of the Rehabilitation Act. And they do a lot of the same things that the ADA does. It's sort of the precursor to the ADA. What's different is what employers and whether other providers are covered. So the Rehab Act basically covers federal agencies and also entities that receive federal financial assistance. They also cover federal contractors. So discrimination by entities that receive federal financial assistance is governed by the Rehab Act. Discrimination in a federal agency, likewise. So same kinds of protection as the ADA, but a different set of individuals and entities that it applies to. The third thing on this slide is the Patient Protection and Affordable Care Act, the ACA. And this has various provisions, obviously, but it has an anti-discrimination provision in it, Section 1557, that protects against discrimination on the basis of various protected classes, including disability. And it applies to healthcare and healthcare providers and health insurance plans. So again, some similar kinds of protections, but a different group of entities that are covered by it. Next slide, please. The last three laws I'm going to mention are the Age Discrimination in Employment Act, which protects workers who are at least 40 years and older from discrimination on the basis of age, applies to employers with 15 or more employees. And it is not about disability on its face, but a lot of older workers may have disabilities. And during the pandemic, we saw some particular kinds of discrimination against older people because of the fear that they might be more susceptible to a severe case of COVID-19. And so it kind of gets mixed together a little bit in certain circumstances. So we're mentioning it here. The Family Medical Leave Act, FMLA, applies to 50 entities that have 50 or more employees and various other sort of restrictions. So this is a little bit, these are a little bit larger employers than either the ADEA for age or the ADA for disability. And what it does, it's not an anti-discrimination law. It is a law that guarantees a certain amount of leave per year. And that can be unpaid leave, but that's a very important protected activity. And it can be leave to care for oneself or leave to care for someone in the family that the person has responsibilities for. And then finally, the Fair Housing Act. The Fair Housing Act protects against discrimination on the basis of various protected classes, but including disability. And this obviously is focused on housing discrimination, discrimination in the renting or selling or financing of homes. And it also applies to nursing homes and other congregate facilities like that, or it may apply, as may the ADA. So again, these are the main federal laws. In addition to these, there are state and local laws which are beyond the scope of this because none of us can address all of them. But the point I would make is that there are various laws, they apply to different groups of people, but there's a big overlap. And so it is very likely that the patients and clients that you encounter will have some protection from disability discrimination by under one or more of these statutes. The last slide that I'm going to talk about right now is sort of the counterpoint to that. Although most of the clients and patients that you will encounter have protection, it is possible that someone may not have any protection. So for example, if we were just looking at the ADA and just looking at employment discrimination, if the individual worked for an employer that had fewer than 15 employees, then they are not covered by the ADA. And so the ADA doesn't stop that employer from discriminating on the basis of disability. Other limitations under the ADA, it's 20 or more employees under FMLA, 50 or more within 75 miles, and also some restrictions on how much the individual has worked for that employer. So it can get complicated. But again, I think the main point is some individuals are not governed or not protected by a federal law, but most, the large majority are. And so it helps to have a sense of what those are so that you can help the individual sort of spot where the protection might lie for them. And with that, I'm going to pass it back to Katie, I think.
Thank you, Brian. So now that we have given a real overview of what the laws are, let's talk about what they mean in the workplace. And for that, I will turn it over to Aaron.
Okay. Thanks, everyone. Can you hear me okay? Yes? Good, thank you, Katie. So before I jump into a few slides and information, as Katie mentioned, I was a lawyer working at a medical legal partnership in my past professional life, and there were just so many ways that working side by side, lawyer advocate and healthcare provider, bore such positive fruit. And helped patients and clients navigate really challenging aspects of their lives, including in the workplace. So for all of us searching for a job, having a job can be challenging and stressful. And for people with health conditions, disabilities, there's this extra layer of anxiety, uncertainty. And so I really feel like working together at Lawyer Advocate and healthcare staff providers is just such a great way to smooth a bumpy process and address problems or issues as they arrive. So next few slides are going to talk about how the process looks at work and how to apply kind of a can-do approach to help our clients and patients navigate things. So the first slide is about disability inquiries and examinations. They're simply questions about the existence of a disability. Examinations or requests for medical information about a disability. They can be on job applications or job forms or in medical questionnaires or other employment paperwork. They can pop up in a number of different ways. But the ADA, what the law limits is when and how employers can make disability-related inquiries and when they can require medical exams. And there's sort of three stages here. One is the pre-job offer, the post-job offer, and then as we'll get to in a moment, during employment. So pre-job offer, employers cannot ask about any disability questions or require any examinations. That's in the application interview process. Now, that being said, for some patients and clients with a disability, they may need a reasonable accommodation. They may need some extra assistance in that process, and so we'll get to that soon. In the post-job offer stage, employers can ask disability questions or require medical exams or information, as long as those things apply to all similarly situated employees. So it can't be sort of targeted or specific. Go to the next slide. Okay, so during employment, and this is where a lot of the issues arise. Employers can ask disability questions and require medical exams when those things are job related and consistent with business necessity. Oftentimes, it really depends on the job, that healthcare input is best coming from the employee's treatment provider. So what are some of the scenarios? One is when there's a reasonable belief based on objective evidence that the employee's ability to perform essential job functions, basically what are the core components, requirements of their job, when their ability to perform those essential job functions may be impaired by a disability. When there's a reasonable belief based on objective evidence, again, that the employee poses a direct threat that may be related to their disability, direct threat to the work environment, to themselves or others. When there may be a need for a reasonable accommodation in the workplace, and when it's required for things affecting public safety people. And that often comes up in the context of police officers, firefighters, and the like. One thing just to sort of hold on here is when we're thinking about an employee's ability to perform essential job functions under the ADA and a lot of state laws, it is essential to add to that with or without reasonable accommodations. So they may require a reasonable accommodation in order to successfully and safely perform their job, and that's okay. It is the employer's responsibility to work through that and provide those accommodations to allow people to succeed at work. So let's go to the next and give some examples. Reasonable accommodations. We heard about it a little earlier, but it's some references to it, but it's essentially any way that the job setting or work environment might be modified from what's normal to allow a person with a disability who's qualified for that job to perform the essential functions of the job, and also to enjoy the benefits and activities and programs related to the job. So to have an equal opportunity to participate and perform. As I mentioned before, during the application or hiring process, there may be a need for a disability accommodation, maybe related to how the interview is conducted. If there's a number of examples, allowing a service animal to join the person, or having a sign language interpreter, various examples of how in the application process there may be a need for accommodation. It can also be at any time during the employment that someone needs an accommodation. Doesn't need to be in writing, but always nice to have it in writing. And healthcare providers definitely play a significant role in making that a successful request. The worker needs to disclose their disability and relevant information about how it impacts their work to the extent necessary. So you don't need to overshare. You don't need to provide medical records. You don't need to get into medication information generally, or other private medical information. It's enough to address any concerns about the person's ability to perform the job, and to support the need for the reasonable accommodation and how it can be successful. A request for an accommodation initiates an interactive process, which essentially means employer and employee are working together to find an effective solution. Examples of reasonable accommodations. For someone with diabetes, it might be a break to check their blood glucose, to address a low or high blood sugar, to take medication. For a variety of disabilities and medical conditions, it can be particular leave to be able to attend medical appointments, get treatment, training, that sort of thing. As Brian mentioned before, under the FMLA, there is a requirement if the person is protected under the FMLA to provide a certain amount of leave. Well, a reasonable accommodation might be some additional leave, generally not open-ended leave, but some relief beyond the period of time that the FMLA requires if that person needs it to get treatment or to address a disability-related need. It can be a reassignment to another job or vacant position, generally an existing job. That can be a reasonable accommodations, reasonable modifications to job tasks, physical modifications to the workplace. I'm working with an individual right now who has some disabilities following some injuries and other medical issues. And it's a physical activity in providing a platform so the person doesn't have to bend over with heavy equipment and that sort of thing. Other examples might be software that allows someone to work in the system if they're doing work on computers. And in some cases, it can be particular work scheduling, a remote work or telecommuting arrangement that is reasonable and works for everybody. Again, some things that generally are not, in our experience, does not fly as reasonable accommodations. The idea being that it can't impose an undue hardship on the employer operation of the business, fundamentally change what that job position is or how the workplace operates. So it could be long-term reduced workload, not working as much as someone else in that job. Reassignment to a different supervisor. With some exceptions, it's difficult to navigate that. Creating a position that doesn't exist. And reassignment to a position for which the employee isn't qualified. Those generally are not reasonable accommodation. One other consideration is direct threat. That is a legal term, which essentially says that an employer does not need to accommodate or allow a person to work if their disability poses a direct threat to the health and safety of that individual or others in the workplace. It is a defense that employers may use to either not hire or fire somebody or to refuse to accommodate them. It's the employer's burden to show that there's a substantial risk of harm from the disability, and it needs to be specific, needs to be objective, and it needs to be sort of evidence-based. Two important points here. One is that reasonable accommodations may address a direct threat. There may be, it may not be safe for somebody to be moving heavy equipment around a factory floor, as someone just mentioned. If they drop something, they may hurt themselves, they may hurt someone else. But with the platform that allows them to move heavy materials safely, that direct threat is addressed, and the person should be able to work. And the second point is that healthcare providers are in the best position to help navigate these concerns, to provide information about what the person's abilities are, what the risks truly are objectively in an individualized sort of way, and how those things can be addressed in the workplace. Great example is direct threat of somebody having the diabetes world. A low blood sugar can be a dangerous situation while somebody is working. However, if they're able to check their blood sugar and address blood sugar lows, which can be done timely, simple way, then and the healthcare provider can help provide information about how the person's able to manage those things successfully. And that's a way to address what can be perceived as a direct threat. So all of the big takeaway is navigating each stage of this process. Health providers are in a great position to provide information to help people navigate things, talk through things, think about things, about what accommodations they're going to ask, and then address concerns that employers might raise along the way.
Thank you, Erin. So now that we know what the law says and what it requires, let's apply it to some common barriers. I'm going to read this next case study that is on the screen, and then we will discuss it. So Lucia is a highly sought after sales director at a large pharmaceutical company where she has worked for the past 8 months. She was recently diagnosed with cancer and used her paid time off to undergo surgery, recovery, and start her cancer treatments. She has several more months of treatments remaining, but has run out of paid time off. For the past few weeks, she has been struggling to work full days and to meet her sales goals, due mainly to fatigue. Her supervisor and other coworkers are aware of her diagnosis, but Lucia has not made any requests related to her cancer at work. She knows from coworkers that the company refuses to allow any employees to work remotely during the COVID-19 pandemic. And although she was heavily recruited to join the company and exceeded her goals prior to her diagnosis, Lucia now fears a bad review and even termination for not being able to keep up. She comes to the health center complaining of extreme fatigue and stress. So I'll pose the first question to Brian or Erin and ask you what possible legal violations exist in this scenario.
Well, I'll start and then I'll let Brian jump in. So the first thing that pops out to me is that it appears that the employer is aware of Lucia's diagnosis and potential needs, and hasn't done anything to discuss a need for accommodations through that interactive process, to sit down and get more information and to see what reasonable accommodations she might need to be able to navigate things here in the workplace. That examples could include some additional leave beyond even though she has run of paid time off, sort of a specific amount of days, adjustments to schedule, I think there's a number of sort of things here that I think could be addressed through that interactive process.
Yeah, I agree with all that. So just to highlight, leave without pay, beyond paid leave can be a reasonable accommodation. So
Yeah,
that's certainly a possibility. And then although changing a full-time job to a part-time job is not normally required as a reasonable accommodation, the employer could choose to do it, but more likely a temporary period of part-time work might be a reasonable accommodation. The last thing I would say here is, although the employer's aware of her diagnosis, it's a little less clear what they know about how it's impacting her and what she needs. And so I think one of the things to think about for Lucia is whether she needs to go ahead and request a reasonable accommodation, because it is possible for the employer to say, yeah, we knew she had cancer, but we didn't know that was the reason for whatever was going on at work. And she just became a poor performer. And so we had to let her go. And it wasn't, as far as we knew, it wasn't about the disability. And I think she could sort of address that more directly by saying, it is impacting me this way. These are the things I need. And it also gives her a little bit more protection, because in general, she's protected from retaliation for requesting an accommodation. And so I think, being upfront with the employer and telling them what she needs and then negotiating with them about what will work for both parties is good. She's obviously got some fear of bad review because of what's been happening, and she may fear a reaction to her request, but in general, it is a good idea for the employee that needs something to let the employer know. And then as Erin said, the thing not to ask for here is indefinite leave. So she doesn't want to say, I need time away from work. I have no idea when or if I'll be coming back. That does not sound like a reasonable accommodation, and most deciders of that will say it's not. So she needs to, be more specific. I need an additional 60 days of leave and should be able to return at such and such a date.
What about her sales goals or other sort of more marginal job duties? Can she ask for changes to either of those?
Well, so reduced productivity is a riskier place to go. So saying that I don't want to be expected to meet particular sales goals because of my accommodation, that sales goal, that target may be considered an essential function. So that's a difficult one to navigate. In terms of marginal job tasks, other things that might be stressful, contributing to fatigue, and that can be reasonably shifted elsewhere. That may be a useful accommodation and a reasonable accommodation to ask for, depending on the situation. It's certainly something to, I always talk to clients and say, you want to present yourself as a can-do person? I can do it. I can do the work. Here's how you can help me be successful. So you don't want to send the message that I can't do the job. But in terms of here's how I can navigate things, and if I can not be required to manage this component, then I'll be successful in what are the core essential functions of my work, that sort of thing.
Great. Cindy, what can the health center do in this situation? And I know I'm jumping a little bit ahead to your next section, but what are some of the sort of basic things that a health center might do to engage with this patient in this situation?
Yeah, thank you, Katie. I think the first thing the health center can do is to advocate for Lucia. And when she comes to the center and meets with several of the staff, they can listen carefully to what she is saying and try to understand how she's feeling and how it's affecting her job. And as I'm going to talk about shortly, being a real active listener and patient advocate are two things that several different roles in the health center can do to support her, advocate for her to have reasonable accommodations, and then to communicate what is necessary with her employer along the way to assure that she is able to do her job and yet care for her health.
Agreed all around. Looks like she's in good hands.
Katie,
So
do you want to address the hand that's been raised? Keith has a
I
great
do.
question.
If you, yeah, I haven't looked at it, Aaron. So
I'll
if
read
you're
it out.
familiar with it. Great.
Keith asked, please discuss the difference between physical and mental disabilities, including privacy required for psychiatric treatment. So I can touch on that in 30 seconds, I think.
Go for it.
I think it's a great question, and it is more and more present in the world as I see it. More and more people are calling with concerns about related to mental health in the workplace and so forth. So it's a really important question. As a general matter, physical and mental disabilities are the same, get the same protections. If you have a disability, then the same protections apply. And the federal government and other entities have put out lots of guidance on how psychiatric, cognitive, other mental health related disabilities apply and give you those same protections. Practically, they can be more challenging for reasons related to privacy and all sorts of other concerns about a person's ability to do the job and just sort of how people perceive mental health related disabilities. And so there's a lot of ways to sort of answer your question, Keith, but one is on the privacy front, you don't always need to provide a diagnosis, but you need to give enough information, you employee and healthcare provider, to address a concern that the employer has about the person's ability to do the job and to justify an accommodation. To say that this is something that they need and that it will make them successful. So providing instead of a diagnosis, you can provide ways that the person has anxiety or maybe is subject to maybe more vulnerable based on trauma without getting into what the trauma is or that sort of thing to help navigate what might be, might feel like sensitive information for an individual. The one other thing I'll say is it generally is not a reasonable accommodation to say, I need a stress-free workplace because one person's perception of stress may be different than another's. It's really, here's what you can help me to do to address the challenges that I have related to stress or organization or being able to complete complex tasks or understanding complex directions or those types of things. There are a number of accommodations that are available and tried and true to help people with those types of disabilities.
I would add to what Aaron said, which is exactly right, that the privacy issue is there are rules under the ADA and other laws that restrict what private medical information can be shared within the workplace. So if that employee is sharing private medical information in a reasonable accommodation request, the employer needs to keep that confidential and limit who has access to it. So whoever may be involved in the provision of the accommodation may have some amount of access to some amount of that information. And in one of the examples that Aaron just gave, I think focusing on what it is that the patient needs in the workplace and how it will help them do their job and not on the diagnosis will make it more likely that that information will be appropriately limited at the employer's business. So that if the HR person receives the reasonable accommodation request and has the information needed, presumably and hopefully the HR person can work with the manager or the supervisor to share only what's needed to effectuate that accommodation and not to speculate based on a diagnosis. So I think that just provides more rationale for not just sharing the diagnosis and letting people's imaginations run wild and providing really practical information. There are no other thoughts on this. We will move on The next section we will talk about are some of the protections available when accessing public programs and activities and places. And just a note here that what we are highlighting today, the anti-discrimination laws that we're talking about in these scenarios, we are focusing on the workplace and accessing public programs and places because we think that's most likely where health centers and health providers may get involved, but it is by no means the only legal protections that exist. There are others around transportation and communication and all sorts of other things, but in the interest of time and wanting to dig in and have a conversation, this is where we have focused today. So, Brian, can you tell us a bit about reasonable modifications?
Yes, so reasonable modifications are, it's a similar concept to reasonable accommodations in the workplace, but the statute typically describes them as reasonable modifications when it's not the workplace situation. So for example, someone going to the grocery store or a lawyer's office or a doctor's office or a hospital, they may need a modification to the way things are normally done in order to have access to the services and benefits. So that's all it means. And like in the employment context, lots of things can be a reasonable modification. The parties can be creative. There should be sort of this interaction between the parties, but it doesn't have to, the modification doesn't have to or shouldn't fundamentally alter the nature of the services or activities or goods or facilities that the entity is providing. So we sometimes see this when there is, sort of a normal way of doing things, and it was not undertaken, this policy or practice was not undertaken to discriminate against anybody, but it does pose a barrier to someone's full participation. And so it may mean that the policy, which can continue as a general proposition for the entity, but it has to be flexed as a modification for a person with a disability who needs it because it will be reasonable to do that. So there are various kinds of modifications. One that's gotten particular exposure and also has particular protection in the law is allowing a service animal into a facility, even if there is a no pet policy. So service animal is not a pet. A no pet policy can be maintained, but the entity also has to allow someone to come in with a service animal. And so this terminology is what we use in the non-employment context, but the concept is exactly the same. There's sort of this barrier that has been created, and to get equal access, there needs to be a change to some policy or practice, and the parties should strategize about what will work, and it doesn't have to be a fundamental alteration.
Great. Thank you, Brian. As you can imagine, as Brian alluded to, just like in the employment situation, there are all kinds of policies, practices that may need to be modified or changed or flexed. I like your terminology there, to ensure access by people with disabilities. So let's discuss one example, which may sound somewhat similar to what Brian was just referring to as an example. Eddie lives with major depression and anxiety, as well as type 2 diabetes that is treated with insulin. As a result of a recent job loss, Eddie is currently unhoused and has been living between shelters and short-term housing in a local hotel using government housing vouchers. At the shelter, he was told there was no resident use of a refrigerator or locked storage area to hold his diabetes supplies and medications, causing him to lose track of them. His anxiety makes this situation untenable for him. He's recently been granted a support animal from a nonprofit organization whose mission is to provide service animals to people living with disabilities. However, both the shelter and the hotel have no pets policies. Eddie comes to the health center struggling to manage his blood glucose levels, his depression, and his anxiety due to these challenges. This, in turn, threatens his chances of finding a new job and more stable housing. So similar to the last case study that we discussed, I'll pose to Brian or Aaron, what are the possible legal violations here?
This is Brian. I'll start and invite Aaron to weigh in. We're not talking about employment discrimination here. What we're talking about is some barriers in the non-employment context. And so, as was mentioned, some of these entities will be covered by the ADA. That is, the obligations that in the ADA not to discriminate, to provide reasonable modifications, et cetera, will apply to these. The Fair Housing Act may also apply to some of these. And the reference to government housing vouchers it's hard to tell exactly what that means, or at least it's hard to tell for me, but that may also bring in the Rehab Act as federal financial assistance. This may not be federal, and some vouchers are not considered financial assistance. But in any event, there are several different laws that I see as implicated here. Access to a refrigerator or storage for things like keeping insulin and keeping the management tools that the person has, very straightforward accommodation, lots of support for that. This entity can have a policy where they don't allow general access to the refrigerators or whatever, but they're going to have to come up with a plan for Eddie that will be different from that, because Eddie needs something different. The other thing, and with regard to the animal, there's some competing things going on here. So with regard to the ADA, in the non-employment context, the ADA generally only protects a service animal. This is referenced as coming from an entity that provides service animals, but it's also described as a comfort animal. And typically, at least legally, we think of those things as different. A service animal is a dog that has been trained to do a task related to the person's disability, to address manifestations of person's disability. A comfort animal is typically seen by lawyers, at least, as an animal that provides benefit to the person just by their existence. The dog or other animal doesn't necessarily do anything, but its very presence can be very beneficial. So the ADA is really focused on service animals, at least outside the employment context, a little bit less specific there. But other laws, and in particular the Fair Housing Act, does not have that limitation. And so a non-dog or a dog or other animal that provides help to the individual just by its presence may be protected, and it may be a reasonable modification to allow that in the housing context, even if it wouldn't be under the ADA's provisions that apply to private businesses or governmental entities. So those are my first thoughts.
Thank you. Cindy, this individual, Eddie, has multiple disabilities, multiple conditions that he is living with. What benefit, or what can the health center do, or is there any benefit, I guess, to perhaps being the place that is treating all three of these conditions for him?
Yeah, definitely. A health center, most community health centers or federally qualified health centers do have services that would treat his medical condition as well as his mental health conditions. And those providers can work with Eddie to find housing, perhaps long-term housing, as well as the enabling services staff. And should Eddie be in a health center, he would be meeting with several people on the enabling services team as well as his providers. And that provides him many opportunities to talk about his needs and what accommodations he needs. And he would have a whole team of health center people looking out for him and being able to connect and refer him to housing that's available that would allow him to store his medication, have his comfort animal or his service animal, and they would also provide follow-up with him to make sure that these ongoing accommodations are continuing and to monitor his health and his diabetes and to assure that his mental health conditions as well were improving or at least being treated, and that his circumstances outside the health center allowed him to continue to be healthy.
Great. Thank you for that. So now that we have covered the legal protections and we've gone through a couple of the common barriers, I'm going to turn it over to Cindy to dig into a little bit more. We've touched on it, but the role of the health center in addressing disability and chronic disease discrimination.
Yeah, thank you, Katie. Well, the health center's most important role here is to be an advocate for their patients. There's many ways they can support their patients to achieve better health outcomes by working with their health center teams, the community partners that health centers have relationships with, as well as their other colleagues to eliminate barriers that prevent good health, including discrimination. This includes helping their patients navigate the healthcare system and the processes in this health center and in the community, which includes screening for the social determinants of health and helping the patients to navigate referrals. Both providers and enabling services staff do not need to be specialists or attorneys to be effective advocates. They have medical authority as well as medical expertise, as well as social service expertise. So they are able to connect with employers and they have the knowledge of the conditions that the patients have and how it impacts the patient's day-to-day lives. They can put that to good use by writing letters to be available to consult with employers as healthcare providers. They can use their training to conduct focused and appropriate medical examinations when it's required. Additionally, enabling services staff also have special knowledge of the community resources and can advocate for patients' social needs. So they have what they need and are supported in other areas of their lives that affect their wellness and good health. Next slide, please. One important role of the health center is to screen for discrimination. It's not often thought of as the primary role, and so this requires health center staff to be active listeners, to be on the lookout for hints and subtleties that come up in conversation with patients as to possible disability discrimination. Health center staff should have an awareness that discrimination may be going on or occurring without the patient even knowing or having an awareness themselves that is happening. Health center staff should be trained in behavioral interviewing. This comes up in our work at Health Outreach Partners quite a bit. We do a lot of work with health centers to screen and document for the social determinants of health, as well as in enabling services, and do a lot of training around behavioral interviewing. And when you're talking with patients, establish certain data. And while you're taking data, just be really conscientious about the questions you're asking, such as the employment status of your patients and what problems might be occurring. Staff should know what questions to ask and where to probe, and to listen to things that patients characterize as their worries. Things such as, I'm worried I might lose my job, which isn't necessarily directly related to their visit or their health needs. Also listen that they might be worried their boss finds out they have diabetes, for example, or they might be fired. Just those subtle clues that come up in conversation for health centers to be aware of and to ask more follow-up questions about. As a provider, when you're reviewing the clinical data, ask the patient what he or she believes is impacting their data. For example, ask patients if they come in and their hemoglobin A1C level has been elevated since their last visit, ask them what they believe might be the reason for that. Are they in a new job? Are they given sufficient breaks where they can check their blood sugar or have a snack? These are things that should be part of the routine visit, documented in the chart, and have follow-up on. Have a conversation with your patients. Really take the time to listen and to ask open-ended questions. Next slide. So the role of the provider is extremely important in advocating for patients in a health center, but it's also, I don't want to overlook the role of the enabling services staff. There are many opportunities in a health center visit to have a touch point with a patient. And enabling services staff hold many of these roles, such as patient navigator, community health worker, health education team members, case managers, even the translation staff, the transportation team, or the enrollment and registration staff. There are opportunities to build relationships with the patients, get to know the patients and their clinical concerns and their employment status, and to screen for the social determinants of health that may be affecting their health outcomes. Implement in that initial screening activity these opportunities for touch points and to listen actively at what your patients are saying. Focus and emphasize on screening everywhere that the patient opens up and shares with staff. There are multiple opportunities for this, and oftentimes the clinical staff have limited time with the patient. And if discrimination could be identified during these other interactions with enabling services staff, the clinicians or the medical team could be brought in and used efficiently for direct patient advocacy. Next slide. So I'm going to review some tips for health centers. Many are reiterated from what Brian and Erin have already talked about and are just how health center teams can work in parallel with the legal team. Your patient's ability to keep their job and income depend on getting reasonable accommodations. And the health centers play a critical role in helping patients with disabilities keep their jobs and their income. Health center staff are empowered and should be ready to support and advocate for their patients. A few things to keep in mind if you're a health center staff person and this is new for you, that you may be asked to provide medical information for your patient. And even if they don't ask you to write a letter directly, your role is to support them and be ready to provide this information. It's important to respond to these requests promptly and with information that is helpful and responsive and accurate. The law requires that employers keep employee medical information confidential, and that includes any letters that you may write on behalf of your patients. We recognize that not all health centers have a medical legal partnership, and they are a powerful tool to help address discrimination. But if you don't have one, know that you do not need to be a lawyer to help your patients by responding to these requests. Okay. Next slide. How do you support your patients with disabilities? You can do so by providing the medical support for an accommodation request or other assessment for your patient. Write a letter of support that states your professional qualifications as their provider at a health center, the nature of your relationship with the patient's diagnosis, and the impact it has on them at work. provide an explanation of how the patient's condition requires changes at work. It's important, though, to limit your letter to the specific problems helped by the accommodation. Having worked in a health center before for many years, we would get medical records that would have all sorts of things that had no relationship on what we needed. It was really challenging to navigate that and often provided a lot of information that was not necessary. So really keep it narrow in scope to what is needed. Just to review what an accommodation is, which was already covered earlier, it is a change in the way things are normally done at work that allows someone to do their job, apply for a job, and to be able to function in their job and be fully productive to the level that they are able. It's always helpful as a medical provider or health center staff to suggest accommodations to the patients that you think might be effective, such as an alternate break schedule, an alternate work schedule, time off for medical appointments, eliminating non-essential job duties, part-time work, or telecommuting. Don't provide records for a patient unless they have requested it. Some information will be unnecessary or misunderstood by the employers. Resist the urge to discuss the patient's medical profile beyond this request. And lastly, just a quick final review of what medical teams and health center staff should not request. And I think Erin already covered this, but is an indefinite leave. If you are requesting a leave, please provide a return date. Don't request a new supervisor or a stress-free work environment. I mean, I'd like to request that, but you know, I think we all would at some point. Don't request creation of a new job or permanently lowering productive standards. These, as is already noted, would be considered not reasonable and often not accommodated. And given that, thank you, Katie. I'm going to turn it back to you.
Thank you, Cindy. So on this slide, there are just a few resources that healthcare providers may find useful to help you advocate and support your patient's requests. You'll see the American Diabetes Association has a sample letter showing how you can document the need for some diabetes-specific accommodations in the workplace. Disability Rights Texas also has several sample letters, a general letter. There is a letter requesting accommodations for a person who lives with ADHD, and a letter requesting a leave of absence. And the third thing is actually in the middle of this slide. Disability Rights Texas also has a really wonderful 5-minute or so video that explains the importance of supporting these requests, and as well as some of the do's and don'ts that Cindy just talked about. And I would suggest, if you have colleagues who couldn't make today's webinar, but who would benefit from this and they only have 5 minutes, this is a really great resource to share with them to help them feel comfortable participating in this process for their patients. So we are going to perhaps pick up the pace a little bit here. I want to get through these next 2 case studies and leave some time for your additional questions. So we have a couple of case studies that highlight what discrimination might look like in specific populations or identities, sometimes where there are no easy solutions. So this one is about Frank, who lives in California, where he works as a farm worker growing produce that is shipped and sold around the country. Although his job site changes from farm to farm daily, he is employed by a large multinational corporation who hired him through an H-2A guest worker program as a seasonal agricultural worker. Frank's wife, children, and extended family remain in Guatemala. Since arriving in the US, Frank was diagnosed with type 2 diabetes and hypertension. He was diagnosed at a community health center, but has only been able to access care sporadically due to his erratic work schedule and long hours working. Recently, Frank began experiencing numbness in his left foot and lower leg. It has slowed him down at work, and he's been berated for not getting as much work done as others. He has seen other workers terminated for complaining about work conditions. Frank arrives for a long overdue checkup with a hemoglobin A1C level of 12.6. Reticent to complain, Frank finally admits his employer does not allow breaks and he has not spoken up about his diabetes. So I'm going to start with Cindy on this one. What can the health center do for this patient? Or what considerations are involved here that the health center needs to understand?
Well, to answer your first question, I think the first thing the health center can do is to first care for Frank's diabetes condition, but also to connect him with a case manager who can help to manage his diabetes through the social determinants of health. And one thing that we see often in health centers is that farm workers often go to the community health workers first and foremost as their trusted healthcare provider. And having the community health workers be part of your care team in the community health centers is really pivotal to connecting with farm workers and having them be part of the care team and being able to provide education and referrals to farm workers so that they are able to get the healthcare they need. And lastly, community health workers often will advise farm workers and other agricultural workers on ways to communicate with their employees or the farm worker advocacy organizations in their communities. And those are the folks that agricultural workers trust the most. So if all of these roles in the health center work together as a team with the clinical team, they have a better chance of helping Frank get the accommodations he needs in order to care for his health. It's a real team effort that must include the enabling services workers, which does include community health workers.
Great. I'm curious, Aaron or Brian, recognizing that there may be, immigration concerns here, maybe an interest in not rocking the boat, which happens with a lot of employees, not only because of immigration status. Any comments on the legal side of this? And if Frank were willing to move forward, what you would recommend he do?
This is Brian. A couple of comments. One, the ADA would protect Frank if he is an employee. So the fact that he is an immigrant, whether he's outside of legal status or not, wouldn't prevent him from being protected. It could impact the remedies that he gets, but in general, the law would apply in the same way. But the question about retaliation for requesting an accommodation or other things like that, it's a tough one, and it's one that we face all the time with our clients, as you say, sometimes about immigration status, sometimes about other things, and we just have to talk to them about what happened, what's supposed to happen, what the law says, what would happen when you do this thing, and just get them to a place where they can make a decision. The decision might be, I'm not going to do it. Or the decision might be, I am going to do it. And then if they say they are going to do it, then we help them write a request for accommodation letter of the type that we've been talking about here, and would hope that their healthcare givers could support them in doing that. One last thought I have, and this is really ignorance on my part on all the things that medical legal partnerships can do, is whether there would be an opportunity to reach out unrelated to Frank, but just generally for the health provider to offer a presentation to the employer that has nothing to do with Frank or any other particular person, but just like, here are some things that you should know. Here's how it will help you if you allow accommodations, because your employees will be healthier. And maybe that could reduce the risk when someone like Frank is forced to request an accommodation.
Very good point, Brian. Go ahead,
And I think that's a great idea. It's possible, but the general theme is kind of a constructive can-do approach, which is whether it's for the individual, for the group, providing these basic accommodations are doable, and they're going to make your employee more successful, and it's going to make the workplace more successful. And so that's the work and the education piece that I think healthcare providers are uniquely situated to provide.
Good point. Okay, I'm going to move on to our last case study. Alice is a 66-year-old Black woman with diabetes who works for a large retail company. For most of her employment, Alice's diabetes has been fairly well managed. Recently, a new manager came on board and changed several store policies, including instituting new split shifts for some workers and deducting points and pay for each work absence not scheduled and approved in advance. Alice has struggled with these new policies, and her blood glucose levels have taken a nosedive after working so many split shifts. Last week, she had points deducted for calling out sick for 2 shifts and lost her full pay for those shifts. Yesterday, Alice went to work despite feeling shaky and experienced severe hypoglycemia or low blood glucose while assisting a customer. Her manager sent her home and told her she could not return to work until she was cleared by the store's doctor, who won't even see her for 3 weeks. A group text with some coworkers revealed that the only people being given the split shifts are those who have worked there many years or are older. Alice needs to keep working, but does not know what to do next. So the open-ended question for our lawyers on the panel, what are the possible legal violations and what would you advise Alice to do?
It sounds to me like disability discrimination. It sounds to me like age discrimination because of who's getting assigned these shifts. It is a little bit, the age thing is a little bit less clear because they're not doing it based on age, but based on, if I understood it correctly, based on, sort of time with the company or something like that, which is sort of related to age, obviously, but not exactly the same. But in any event, it sounds like she may have protection for both things. It is true that the employer can, in many circumstances, can request that the employee go to the employer's own doctor to get information. But here, there's this delay, which is going to cause loss of pay. One thing that I might recommend is that she request as a reasonable accommodation a fixed shift or whatever change in the shift that she needs, and offer from her own caregiver the information that should be sufficient to make that, to realize that she has a disability and this is an appropriate accommodation. And so that might be offering a letter from her own caregiver. They may still say, we're going to make you wait. That may be a violation of law, but she's trying to sort of provide another way forward here. The last thing I'll say is there are times when courts have found a particular strange shift schedule to be essential. It strikes me as unlikely in most cases, but that just sort of reminds us that if something is an essential function, it doesn't have to be changed, at least not permanently. And if something is not an essential function, then changing it is a very typical accommodation. So those are the first thoughts I had.
Thank you. Any other panelists have any other thoughts on this one? Brian's been so comprehensive, we haven't needed to jump in to supplement. Without any, I know we have gone a little bit past, I thought we'd have a little bit more time for open question and answers. I know we've answered a couple in the chat box, but this is an opportunity for you to ask questions of us. We will also follow up with any questions that have been typed into the chat box or the question and answer box if we haven't had a chance to answer them live, to get back to you on those. So if you have any, please type them in. While I wait for you to think of them, I'll address a couple of the questions that we got on the registration in advance of today's session. Somebody asked, describe the differences and similarities between how behavioral health versus medical disability cases are handled. And I'll start by saying I'm not an expert in behavioral health, but I think an important thing to remember here is that disability discrimination law will cover people who have impairments, regardless of where those impairments originate. So if a person has a condition, maybe an anxiety disorder that impacts them in many ways, including how they behave, and that maybe produces physical symptoms, it doesn't really matter whether that disabling condition is considered a behavioral health issue or a medical disability. That may be relevant for clinical purposes, for treatment options, but it's really not determinative for legal protections and purposes. What matters most for legal purposes is whether that mental or physical condition poses a substantial limitation on one or more major life activity. If you can prove that the law covers you, and then you have those protections. Another question that we got, and I may ask for some clarification here, referred to medical legal partnerships and the Veterans Administration. I'm not sure if there was a specific focus of that question. So if you pose this question and you're on and you want to jump in and help me better understand it, please do. If you're asking whether veterans can be served by medical legal partnerships or whether there are medical legal partnerships for veterans, my answer is yes, and I don't know. And it may be that the team at the National Center knows that, and if so, we can get back to you on that. Veterans who have disabilities can be served through a medical legal partnership, just like any other individual who has a disability and may be facing discrimination. They can run into problems with employers or programs or public places, or even accessing healthcare. Unless the issue involves maybe the benefits afforded to the veteran by the nature of their status as a veteran, the legal rights and remedies are the same regardless of the veteran's status. And whether they can be served by a medical legal partnership, I think will depend on how that MLP is structured and what issues they are focused on. So if there are other questions, we have, let's see, Keith asked, please address how to advocate for a person with disabilities that has previously been incarcerated for a low-risk infraction in their attempt to seek employment and reasonable housing. I'm going to open that up and see if the panel has any thoughts on that. I am not sure, Keith, if you're focused on a service-based, like what services a health center may have available to provide for re-entry. Or whether there is more of a stigma or not retaliation if there's discrimination in their status as a previously incarcerated person in the employment or housing situation, if they're being denied an opportunity because of that status. I think if so, the discrimination is perhaps not a disability discrimination, and maybe discrimination based on the status as being formerly incarcerated. Other thoughts from folks?
Yeah, I think this is an intersectional question that people come with all sorts of things in their lives. And I think one thing that as lawyers and healthcare providers we can do is to help pull them apart and address them discreetly. And so we've talked a lot about a person with disabilities who might have accommodation needs, addressing concerns about whether they will be denied employment or terminated because of their disability. It is a separate thing when you talk about people with a criminal record or who are previously incarcerated. And a lot of those protections are going to exist at the state and local level. And so here in California, there are certain protections that I believe are not available elsewhere. So sometimes the best service that we can provide is, here's where we can help, here's where we can help you, and here's someone to talk to, or here's another issue and another avenue to address this separate issue. So pulling those apart, I think is an important and useful service we can all kind of contribute to, but it's an issue.
Thank you, Aaron. Well, I don't see any other questions. And so want to keep us on time. We are at exactly 3:30. Let me see. I think there will be a evaluation, a survey that we ask you to take, and let us know how we did today, what you liked. And please do join us in 2 weeks from today, same time, same place, for the next webinar in this series, which is called Disability and Chronic Disease Discrimination with Kids, Navigating the Health Center's Role in Securing Legal Protections for Pediatric Patients. In that session, you'll hear from speakers representing the U.S. Department of Education. We have an attorney who works at the intersection of disability and immigration, and a health center leader with deep experience in patient advocacy. Like this one, we will cover the legal protections for kids with disabilities, including in immigration custody. We'll discuss the role of health centers in supporting pediatric patients and their families, including some practical tips and resources. And we'll have a similar panel discussion focused a lot on issues involving COVID-19 and kids with disabilities. So if you've been curious about mask issues and other things that have been in the news lately for kids with disabilities, there's a lot of active litigation in this space. Please join us, and we'll be glad to talk to you then. Thank you very much, everybody.